Good morning. So we will continue with the remaining portion of the cephalosporins that I had started on Wednesday. So we were discussing about the different generations of cephalosporins, and I remember we ended with the third generation of cephalosporins, both parenteral and oral, being completely discussed. Now the key features of the third generation cephalosporins, if we quickly review, were that the third generation cephalosporins were active on even those organisms which were resistant to first generation and second generation cephalosporins. The gram-negative coverage was much broader for the third generation cephalosporins. Especially the third generation cephalosporins were quite active on Pseudomonas. One of the unique features of the third generation is Pseudomonas, except for cefixim, which does not have significant activity on Pseudomonas. And then the other feature of this third generation cephalosporins is that they do not have significant action on bacteroids, whereas two of them have action on bacteroids. The two of the third generation cephalosporins which have action on bacteroids were ceftriaxone and cefoperazone. Only those two had, and most of them had a half-life of about 2 hours, so therefore we do appropriate dose adjustment so that we can give them at least 12th hourly. All of them have excellent penetration across the blood-brain barrier. The most high concentration across the blood-brain barrier is produced for ceftriaxone, followed by cefotaxime. And hypoprothrombemia and bleeding tendencies were two important adverse effects rather for development of adverse events in case of people who were receiving either ceftriaxone or cefoperazone, and disulfiram like reaction was common with cefoperazone. So this we were discussing last time, and I said that we will go to the fourth generation cephalosporins when I come back next. So you understand, as you move from first generation to second generation, subsequent to third generation cephalosporins, we gain more action on gram-negative organisms. So we move from gram-positive towards gram-negative, especially we move towards Pseudomonas aeruginosa, because some of the infections that is caused by Pseudomonas aeruginosa are very, very difficult to treat. For example, someone who is neutropenic due to bone marrow depression as a result of aplastic anemia, and someone who is having bone marrow depression secondary to anti-cancer chemotherapy, someone who is debilitated and has a hematological malignancy, or someone who is a burns patient and a lot of raw areas are exposed, someone who is in the hospital admitted for a long period of time and on a ventilator. So such type of people are prone for developing Pseudomonas aeruginosa infection. And the Pseudomonas aeruginosa infection is well known to be resistant to most other drugs. For example, most other drugs like penicillins and ciprofloxacin and all may be actually not able to work on this type of hospital acquired and serious life threatening situations where Pseudomonas is the offending agent. In such cases, the third generation cephalosporins come to our rescue. And I mentioned that very clearly that the third generation cephalosporins are primarily looked up with lot of reverence in clinical practice, very widely used, basically because they have lot of gram-negative organisms, some gram-positive organisms, but basically they have tremendous activity on Pseudomonas, except for the cefotaxime, which was parenteral, and except for the cefixime, which was oral. These two don't have any Pseudomonas activity of clinical relevance. Except them, most third generation do have significant activity on Pseudomonas. The implication of Pseudomonas in clinical practice is very high. First, because Pseudomonas actually causes life-threatening infections in people who are very debilitated and who are immunocompromised. The second, Pseudomonas develop resistance very rapidly. And Pseudomonas, the ability of drugs to cross through the cell wall of the Pseudomonas to bind to successfully any target in it and inhibit it is also very poor. So most drugs fail to work in Pseudomonas because of the complex cell wall structure, which doesn't allow entry of the drugs very easily. Fortunately, we have the third generation cephalosporins, but when I mean third generation cephalosporins, this means cephalosporin of the third generation excluding cefotaxime and excluding cefixime. If you write these two drugs and say the Pseudomonas is susceptible to it, it is not acceptable because Pseudomonas doesn't respond to these two antibiotics in the third generation. Now going to the fourth generation. See, as it is, human beings always very aspirational, very ambitious. They always see the grass is green on the other side of the lawn. So what I mean to say is, whatever we don't have, we always tend to really crave for that much more than what we already have and be satisfied with it. So similarly, first generation we had good spectrum, reasonably balanced one, more of gram positive, some of gram negative. There was no action on anaerobes. Second generation we got little bit of action on anaerobes. The bacteroids were also covered in it. The third generation we lost some action on the gram positive, we got good action on the gram negative. Fourth generation, when we wanted even more enhancement of action on Pseudomonas. So some of the Pseudomonas which don't respond to even third generation cephalosporins we can try and make them respond to the 4th generation cephalosporins. So in the 4th generation cephalosporins, you have two compounds. The first one is cefepime, CEFEPIME, because these are just two compounds and both of them are parenteral. I did not really think of putting it on the slide, so you think you can easily follow it when I say that it is the 4th generation parenteral cephalosporin cefepime, CEFEPIME. So this is a 4th generational parenteral. So what is the feature of this 3rd generation? How does it distinguish itself from the preceding 3 generations of cephalosporins? Particularly, how does it differ from its immediate predecessor, that is the 3rd generation cephalosporin? From the immediate predecessor, the clear difference is that the 3rd generation acts on Pseudomonas definitely, except for the cefotaxime and except for the cefixime. Most of them do have, but even if some of the 3rd generation cephalosporins that act on Pseudomonas are not able to really take care of the Pseudomonas well, not able to inhibit the Pseudomonas well, not able to exert a bactericidal action on the Pseudomonas well, you still have some hope on another generation of cephalosporin, that is the 4th generation cephalosporin. So cefepime can be used even in those Pseudomonas infections which are relatively resistant to the preceding generations of cephalosporins. That is really one of the important features of this. It has got enhanced spectrum of action against Pseudomonas. Apart from that, the action on Klebsiella, action on E. coli, action on Enterobacter, action on Salmonella, action on Shigella, action on H. influenza, action on Proteus, action on Serratia is all there. So it's all there, but addition, it gains more action on Pseudomonas. However, its effect on the gram-positive organisms will be very low. For example, the Staphylococcus, Streptococcus, the action will be very low. Clostridium, the effect will be very low. So that is the difference when you go from 1st generation to 4th generation. The ability to act on the gram-positive organisms gradually fades away. If you ask the effect on Listeria, it will be very low. If you ask the effect on Actinomyces, it will be very low. If you ask the effect on Corynebacterium diphtheria or on Clostridium, the effect will be very low. If you ask the effect on Streptococcus and Staphylococcus, it will be very low. Then where is it good? It is good on Klebsiella, it is good on E. coli, it is good on Enterobacter, it is good on Salmonella, it is good on Shigella, it is good on H. influenzae, it is good on Pseudomonas, especially that Pseudomonas which has become resistant to the 3rd generation cephalosporins. So that is the advantage of this cefepime. Now where do we use this? As I mentioned earlier, Pseudomonas, where does it cause the infections primarily? It causes infections primarily in the people who are seriously sick and in the hospital settings. For example, cancer patients, people with neutropenia, people with skin and soft tissue continuity breakdown, as in people with ulcers and people with burn injuries, people who are on immunosuppressive agents. For example, someone is in the hospital and is in the need of a transplant and he receives a transplant and is put on immunosuppression to prevent the transplant from getting rejected. These are all serious conditions. Someone is in the hospital, put on a ventilator, develop ventilator associated pneumonia, and you find that it is Pseudomonas, and that to the Pseudomonas that is resistant to most other drugs that we use for Pseudomonas. So in that case, what you need is a 4th generation cephalosporin, cefepime. And these indications that you see, they are all serious indications. Someone with neutropenia, someone with immunosuppression, someone with burn wounds, someone with hospital acquired pneumonia. These are all serious infections, and there you need the drug to be absolutely delivered and meticulously available in the plasma with the concentration that are attained and also maintained, because these cephalosporins also, like penicillins, follow the time dependent killing. So you need to maintain the concentrations steadily